Go on to the next presentation from Nizam's Institute of Medical Sciences, Dr. Suresh.
Good afternoon, respected chairpersons and dear colleagues. Today I am going to present an interesting case of stent migration after deployment. It's a 40-year-old male patient presented to us with bilateral lower limb claudication pain since 6 months. He was having moderate claudication pain according to Fontaine class 2B, and his risk factors were he was a smoker and alcoholic. On investigations, CCG was within normal limits, echo it was normal, no RWMA of LV, good biventricular systolic function. We had the patient was referred to us from the vascular surgery department. There they had referred to us for coronary angiogram and peripheral angiogram. So we went ahead with coronary angiogram. It was normal. This is the peripheral angiogram which we had done through right radial artery route. As you can see here, left common iliac artery is totally occluded and with distal reformation is there, and right common iliac artery there is a eccentric stenosis. So the plan was, as you can see, it's according to Transatlantic Society consensus, it is a type C lesion. As per guidelines, type A is suitable for angioplasty and type D is suitable for surgery. So we had discussed with our surgeons and we thought we'll go ahead with angioplasty, and we thought to open the right common iliac artery and even the left common iliac artery. So the access was ipsilateral access, that is through the retrograde approach to the bilateral common femoral artery. So first we thought to do the right common iliac artery, so we put a 7 French sheath in the right common femoral artery, and then the hardware which we took was TERUMO straight guide wire, Cougar XT, Judkins right side holes guiding catheter, the balloon 5 into 20 mm and a wedge catheter, which why we have used the wedge catheter is because we had encountered a complication, which you will be seeing in the due course. The stents were 7 into 33 mm and 7 into 38 mm, pro-star stents, stainless steel stents, that's vascular concept stents. So as you can see, first we are doing the right common iliac artery. As we have the stents which are only 014 compatible, so we had to use a 14 wire, and after 14 wire we had used, and we had crossed the lesion, and once the lesion is crossed we are dilated with 5 into 20 millimeters balloon. So this is the result after the POBA. As you can see, the result is good. And then we went ahead with stenting. So we had taken 7 into 38 mm ProStar stent, and once the stent is deployed, this is the final result, the right side. Then the left side, as you have seen in the angiogram, the pulse, it was total occlusion, the pulse was feeble, it was reformation through the collaterals, so we could manage the access, and once we got the access, as it was a tight occlusion, we had crossed the lesion with TERUMO straight wire, and once after we crossed the lesion, we changed over to 014 PTC guide wire. So once we crossed the lesion, as you can see here, there is a lot of thrombus burden here. So at this juncture, the thrombus aspiration has to be done. So when we don't have dedicated thrombosuction catheters for peripheral arteries like angiojet or anything, then we can use our Judkins side holes catheter, JR guiding catheter as a thrombosuction catheter. As you can see here, we have used this catheter for aspiration of the thrombus. Then this is the result after the thrombosuction. So as we have seen, initially there was a lesion, and then we thought we'll go ahead with stenting. Prior to that, we wanted to prepare the bed and we wanted to dilate it such that the thrombus could be disintegrated. So we had done serial dilatation of the lesion with 5 into 20 millimeters balloon, and once the dilatation is over, this is the result. So we wanted to put a balloon expandable stent as it was available in our shelf. So we had stented with the 7 into 33 mm ProStar stent. So this is the result after stenting. Still there was some thrombus was there, lesion was there, so we thought we'll cover the lesion with another stent. So then we took another ProStar stent, and as you can see here, when we were advancing the stent, there was migration of the earlier deployed stent. This is very unusual for a deployed stent to migrate. It had migrated into the abdominal aorta. And then we had to, the option were you can use a snare, you can use a EMB forceps, but then we had a wedge catheter which we had used to bring the stent to its original position. So we had used a wedge catheter was passed through the wire and then inflated, and then it was, stent was pulled to its original position. And once, as you can see, the stent is crumpled while pulling it back to the original position. So again we had used the balloon to re-expand the stent, and once we had re-expanded the stent, this is the final result. So the take-home message is that in thrombotic lesions, when we don't have dedicated thrombosection catheters like angiojet or Amplant's thrombus extraction system, then we can use our guiding catheter which has side holes, and it can be used for thrombosection. Second thing, when we encounter such a complication like migration of stent, there are other devices, but better to use a wedge catheter which can be used for retrieving. Thank you.
So, good case, but there are certain points when there is this stent migration, as you rightly said, that just shows that stent was not properly deployed actually. It was undersized, and that happens very frequently when you have a thrombus there, because that can also lead to spasm, and you many times wrongly assess the size of the vessel that you are using, and that is why people are now advocating self-expanding stents in these situations.
Yes, sir.
So that is one. Second thing is that, especially if you look at the migration series or embolization of stent series, older generation stent migrations were because of hand-crimped stents. So that was the time when the stent migration rates were like about varying from 1% to even 8%. Yes. But after the balloon crimped stents are available or balloon mounted stents are available, it has gone down to around 0.3%. And now the commonest reason why the stent migrates is when you are trying to put one stent through another stent. That is the commonest reason when the stent migration happens. And the only interesting part is that normally the stent that you are trying to pass through the stent will migrate. Here the original stent migrated, which showed that it was not properly deployed. So
actually,
I think
we had gone to more than nominal pressure. Actually, this post-charge stents this is many whatever the
no, it's not question of going to nominal pressure. It's basically undersizing of the stent, which you would rightly undersize because you don't know the real size because of the thrombus. So there is some thrombus, there is the spasm. You think that the size is 3 and actually the size may be 4. And now you have put a stent which is 3 and gone up to whatever pressure, even 20, 22, still it is under a post. And once you try to put this stent, it just migrates
So
off.
it is 7 mm stent, sir. So
No, what I'm trying to say is I'm just giving you an example.
Yes,
whatever is the stent, you will undersize it actually. That is the problem. So I'm just bringing to your awareness, these are the issues when you have a thrombus. These are the issues in primary PCI as well. That once you put a stent, the important thing is to take a oversized stent and dilate at a lower pressure rather than taking a size of the stent and going at a higher pressure. So that is what is recommended. Also same for SVG grafts, where you have lot of cheesy material there. These are the strategies that one would advocate for overcoming these problems. So or put a self-expanding stent.
Yes,
Actually, in peripheral intervention, ideal to take the CT angio, see the diameter and extent of the length. That will give the accurate idea. What is the diameter and length? They will give. Second one is common iliac artery. 7 usually smaller, usually 8, 9. Sometimes it will be 10. So when you do the peripheral angioplasty, if you are undersizing, definitely it's a huge vessel. Flow will be definitely it will migrate. So it's mainly because of the undersized stent. Another thing is because if you are unable to see the segment, take the CT angio, then see the diameter and length accurately, then customize. That's better.
When the credit is it's Arogeshri, sir, then we have limited option CT.
No, if it is Arogeshri, ideally common iliac artery 8, 9. You have other vessel to compare. What is the size? Both will be.
That other vessel is 7 mm, but it was good enough. Got a good result.
No, we are not saying you did not do what we are trying to retrospect what happened and maybe become wiser for the next case. That's the idea. Thank you very much.